So for those of you who don't know me, I'm going to give you a quick introduction to who I am, and then we'll get started. So my name is Sadie Minkoff, and I am co-owner and founder of Sage Acupuncture in Austin, Texas. And we specialize in reproductive health. And this topic, in particular, recurrent pregnancy loss, really has touched my heart deeply. And I've walked with so many of my patients through this difficult process. So I'm really honored to have this discussion today and get a little bit deeper into this conversation. So we're going to go ahead and get started. And I'm going to introduce to you Dr. Winifred Mack, who is a reproductive endocrinologist and fertility specialist here in Austin at the UT Health Austin Women's Institute, Health Institute. And she specializes in early embryo biology and helps people and patients with recurrent pregnancy loss specifically. So in addition, she is also an assistant professor at the Dell Medical School. So we are very, very happy to have her join us today. Hello, Dr. Mack.
Hi.
It's so nice to have you here.
Thank you for inviting me. This topic is near and dear to my heart.
Absolutely. And to so many people, I think that it's just something that we rarely talk about in our, public lives, but it touches so many of us.
Mm-hmm.
So I think that just to have this opportunity to connect with other people and really get some insight is just invaluable. So would you mind telling us a little bit about yourself and your work and how you became interested in this very specific specialization?
Sure. From my accent, you can notice that I'm not from around here, but I originally grew up in England. I did all my medical training. I have a PhD in genetics also. So I've always been active in research. And so I moved here, about 16 or 17 years ago. And I trained as an OBGYN. I did my fellowship in reproductive endocrinology and infertility. And then before I came here, I was faculty at Yale. And I actually was the director of the recurrent pregnancy loss program there for a number of years before I came here. And so that's really when I started to have a special interest in taking care of couples with recurrent pregnancy loss. And the main reason is that about 50% of couples with recurrent pregnancy loss do not find an answer to why they had a loss. And as a physician scientist, I'm obviously very interested in doing research, and this seemed like a topic that was needed more research and more answers. So that's why I took on the charge, as it were, at Yale to take care of patients with recurrent pregnancy loss so that I can be involved in taking care of them and researching more reasons why couples have recurrent pregnancy loss. And so when I came here, I was recruited to Dell Med to basically head the reproductive endocrinology and infertility division. And I wanted to bring my expertise of recurrent pregnancy loss to the Austin area and basically be able to continue doing research in this area. So I do have a research lab which we have some funding to actually specifically study recurrent pregnancy loss, which I can talk more about later.
Great. Thank you so much. And thank you for your work. So that's really fascinating that 50% of losses never actually, we don't know why they occur. Can you share with us just how common pregnancy loss is in general?
Sure. So about 15 to 20% of couples will experience at least one pregnancy loss in their journey together. And so it's very common. And less common is if you have two pregnancy losses, and which is about 5% of couples. And the more losses that you have, the more uncommon it becomes, thankfully. So at least it does affect everyone. And really, when I talk in sort of work sort of circles, and I mention, that I have a special interest in pregnancy loss, there is always someone, or that I either were touched by a loss or they know a family member. So when you start talking about it, more and more people say, hey, yeah, I had a miscarriage, or I had a stillbirth, or I had, a baby born still at 20 plus weeks. So, you get to sort of know that actually more and more people actually know someone or have had a loss. So you know that it's pretty common for at least one loss to happen.
Yeah, absolutely. I find that when someone does go through this process, all of a sudden, other people to sort of come out of the woodwork and say,
Mm-hmm.
"Oh, that happened to me too." That happened to me.
Right, right,
Yeah,
right.
it would be wonderful if there was just more community support in general up front, so that people knew where to go and what to do, and how to support people going through this
Mm-hmm.
process.
Sure. And that brings me to, yeah, when I was in Connecticut, I volunteered as a board member of a charity called Hope After Loss. And it's very special in that it is a peer-to-peer support group where uh, families that have lost, they actually provide support for other families. And so that was definitely something that was very important when I took part in that in Connecticut. And when I came to Austin, I didn't find as many resources as I thought that there would be. So definitely in the kind of Austin area, there is no equivalent of a Hope After Loss.
Right. Yes, I find the same thing when I've lived in other places as well. So thankfully we are here, and thankfully there's a lot online, but it is really challenging, and I do have I have my little circle of resources that I provide for people, but there's really nothing like talking to people that are actually going through it at the same time as you are, and really can connect on that level. So can you review briefly with us what are some of the causes of loss?
Sure. So usually for when you have one miscarriage, usually those miscarriages, about 60% is due to something wrong with the chromosomes of the baby. And so that's one big cause. And then more specifically for recurrent pregnancy loss, which is two or more losses, there are definitely a few actual reasons that are in the literature that we know of. One is if mom or dad may have abnormal chromosomes themselves, that will affect baby. And so you're more likely to produce embryos or have losses that have something wrong with them, such as a chromosome abnormality. So that's one issue. Two is there's a condition called antiphospholipid syndrome, and that is related to a clotting issue, and that can be screened for by looking at antiphospholipid antibodies. And then there is a treatment for that, which is going on aspirin and heparin. So we know that is part of the workup. And then there could be other conditions such as endocrine conditions, such as having underactive thyroid, hypothyroidism can be a cause. And we know that there's an association with having antibodies to your thyroid and miscarriage, but there's no actual treatment for that. That's kind of understanding that there may be an association and the reason. So maybe that adding to other things may be predisposing a woman to having repeated pregnancy losses. And then other things are if you have uncontrolled diabetes, that's definitely a known cause of repetitive miscarriages. And then if a woman is a little older, so when we say a little older, anybody who is over 35 are more likely to have miscarriages because of their age, because they're more likely to make abnormal embryos due to chromosomes. So I do see women who are losing babies because it's just part of biological aging. And it's not that there's something wrong with them. It's just part and parcel of us getting older and more likely to produce abnormal chromosomes in our babies. And so actually that, if I find that is a reason, then that can be overcome by doing IVF and selecting the right embryo. And so that is an easier fix per se than if I didn't even know why you're having a pregnancy loss. So I would say that those are the main causes that our society, which is the American Society of Reproductive Medicine, have written down that these are the known causes. And then there are other causes that are more controversial that studies have not shown as much evidence for. But I would say that there is definitely growing evidence that the man has a place in this. And, you know, a lot of our testing is focused on the woman, but there is something called sperm DNA fragmentation, which means that the quality of the sperm, there's some issue with the quality of the sperm that can be related to recurrent pregnancy loss. So there've now been quite a few studies of good quality that have shown that men who are of couples who have recurrent pregnancy loss, they have an increased sperm DNA fragmentation. So there is a test that is available through several different laboratories that we can assess that. So that will give you an answer to potentially why. Can we do anything about it? We could try some antioxidants, but there is no treatment or pill that we can reverse it necessarily. But it could be improving sort of lifestyle, not smoking, losing weight. So all those things could help as well. So that definitely is a growing evidence to suggest that that may play a part.
Yeah, that's fascinating, because from our perspective, you know, that is a lot of the work that we do is supporting people in their lifestyle
Mm-hmm.
and helping them with antioxidants
Sure.
and inflammation and reducing
Mm-hmm.
that. But I see around the country places testing for DNA fragmentation, but not so much here. And I'm curious why you think that is, and if somebody was interested in that, how they would go about getting that testing done
Sure.
for DNA.
So I think because it's not part of the ASRM evidence-based workup, it hasn't made it to it yet, that probably there is hesitation to offer it to patients. I think that the ASRM hopefully will be updating their recommendations soon to reflect that sperm may be important in this process, because we do have quite a few studies that show there is an association. So I think that maybe one is because it hasn't made it to the mainstream. And really, if you're in this recurrent pregnancy loss field, are you reading the papers to say, hey, these are the new things coming up the pipeline that maybe we should be testing for, giving more information to the couple so that they can understand a little bit more about why. Because not knowing why and just labeling a patient or a couple saying, oh, you have unexplained recurrent pregnancy loss, really, it doesn't help the couple, and they feel frustrated because they don't know answers. And and the most important is, what do we do? Like, you don't know. So I think the more as more research is being done and more studies, then we can sort of figure out, it's a little bit of this, a little bit of that. Yeah, another thing that that I think there is some association that not everybody also does is to rule out something called chronic endometritis in women. And there have been quite a few studies to look at, sort of smaller studies that suggest that women with recurrent pregnancy loss may have something called chronic endometritis. So I do routinely test for that too. And usually the treatment is to do a course of antibiotics. And so there is evidence maybe doing that may help also with reducing the likelihood of a subsequent miscarriage. It may not be the only reason, but it can be. I think that how I look at recurrent pregnancy loss is that they're probably, apart from the causes that I've already spoken about, it may be that some couples are just more predisposed to having miscarriages because there's many things that are happening. So maybe that the thyroid is a little off and you have chronic endometritis. That combination, if we treat it, maybe then it will decrease your risk of having another miscarriage. So I think there is a threshold, and it's cited in the literature that there is a threshold potentially model of recurrent pregnancy loss rather than you have just this one thing and that's the reason. I mean, I think that there are other things such as genetic causes that we just don't know about that could predispose to recurrent pregnancy loss. But then I think there is a lot of couples that have maybe something wrong with the man and the woman, and it adds together. So a bit like infertility, when we see things like there's nothing obvious, but this is a little suboptimal, this is a little suboptimal, and then you kind of try to optimize both partners, and then lo and behold, they get pregnant on their own, which is great.
Absolutely. Yes, I couldn't agree more that, when we look at the whole picture and the whole couple, and we really optimize overall health, that will trickle down to their reproductive system and support them. Absolutely. So I wanted to just ask a quick question that's coming up in the group, which is that what does the timing of the loss tell us about the potential cause?
Sure. So that's a great question, in that what we observe is that some couples recurrent pregnancy loss couples always seem to lose at a similar stage for that couple. And it can tell us a lot of things. If it's a very early loss, such as a biochemical loss, that would imply that maybe it's a poor implantation, and then so there are some studies which specifically look at using progesterone in the luteal phase of the cycle, and especially for those early losses. So I definitely think that helps so for the early losses, and then the later losses, then that makes potentially suggest that maybe there's some genetic issue that we just don't understand, that we just don't have a test for. And so definitely I'm hoping, I've just written a grant myself to look at genetic reasons for recurrent pregnancy loss. And the NIH have basically asked many researchers to study this. So I think that in the next few years, once the research is underway, we will find some new genetic causes, which if you're having losses at, say, 7 weeks, every time at 7 weeks, maybe there are genes that have been mutated that you're passing down to your baby that really at that stage is causing the baby to pass away. And so as when we get to know more and more genes, then maybe we'll be able to test for those genes for our couples and say, okay, you carry this gene, or whoever, man or woman, and then maybe we might be able to screen embryos through IVF to avoid transferring those embryos and transfer the ones that don't have mutations. So these, I think, will be possibilities in the next 5 to 7 years. I think once we know more and more about the genetics as well, because we right now, apart from you don't have, if baby doesn't have one chromosome, that's as much as we know. There are definitely now that we do microarray for testing of miscarriages, there is finer, like, oh, you lost a little piece of this chromosome. But I think as and when we get more sort of sequencing technology, we'll be able to identify actual mutations, single gene mutations that will allow us to counsel a couple basically, oh, that you have this mutation, that, 1 in 4 chance that you're going to have another miscarriage. So definitely, I think I'm hoping for my patients in the future, and for all patients, that we'll have that information.
That's very exciting. That's wonderful that research is being done for people's futures. So to clarify, when you said early and late, are you meaning first trimester and second
Yeah.
trimester?
So yeah. Well, yeah. So when I say early, when I talk about the biochemical, that's early first trimester. Then you have sort of first trimester losses, sort of in the sort of later first trimester losses when I'm talking about 6 weeks onwards. Then definitely the second trimester losses, there may be more likely to be a genetic cause. And I have been doing, if I have a couple with recurrent second trimester losses, I've been collaborating with my Yale colleagues to really study or really look in depth at single genes. There is something called exome sequencing, which is more and more being used. So it basically sequences the coding regions of the gene, which are what produces the protein, so the coding parts of our genetic material, and identifying single mutations potentially. So that's kind of what I've been doing for my patients with second trimester losses. Recurrent pregnancy loss is a definition of up to 20 weeks. So really after 20 weeks is more sort of, we're talking about stillbirths, which is not something I take care of, but the maternal fetal medicine doctors would take care of.
We have a question about PGT, and if you could explain a little bit about what that is, and then why is it not 100% successful is the question.
Very good. Controversial topic. So what is PGT? So a woman will undergo in vitro fertilization. So what this means is that she will do injections to stimulate her ovaries, and usually every month we have one that's ovulated, but the injections will allow others to develop. And so at the end of the treatment, then we do something called an egg retrieval, where we basically, the woman is under sedation, she does not feel anything, and we basically stick a needle into her ovary to suck up each egg. And the eggs are passed off to the embryologist in the laboratory, and they will be injected with the husband's sperm, and they will be allowed to grow in a petri dish. And so they will be grown for about 5 days. And then the ones that are fully mature, called blastocysts. So the blastocyst has 2 parts to it. One is the inner cell mass, which becomes the baby, and then the trophectoderm, which becomes the placenta. And the embryologist will take a few cells from the trophectoderm, probably about between 3 to 5 cells from the part that's going to become the placenta. And they will send it off, they will freeze it, send it off to the genetics company. The embryo gets frozen and while waiting for the result. So why isn't it 100%? So it is not 100% because you're taking only 3 to 5 cells of the whole embryo, which is about 100 cells. So obviously if you're taking 3 to 5 cells, you're only taking a piece. And you're only taking a part from the placenta. So say if the placenta showed that there's abnormalities, doesn't necessarily mean that the baby has the same abnormalities. So that could be an issue. You are only taking 3 cells out of 100 cells. So there's another possibility that could be sort of an error there. So those are the kind of main issues that when you're just taking a few cells, why it could be potentially that the baby could be totally normal and the result may say abnormal, or vice versa. So thankfully, rarely when we have a normal result that there's something wrong with the baby. But again, I always tell my patients it's never 100%. And I would suggest if they are pregnant to go on to have another type of genetic testing later on to be 100%. So what I talk about is the controversy is called mosaicism. But I think the limit of, so what I tell patients is it's as good as so apart from looking at the embryos, this is like the next more objective way to figure out which embryo may be the best one to transfer. And it helps us a little bit. It's not going to be 100%. So, there's a large controversy that people have had abnormally tested embryos and they become live births. And so that has happened. And so there's a lot of controversy about that. I guess my take really is, yes, they've made a baby that looks fine, but we just don't know the long-term consequences, honestly. So when we talk about baby may look fine and overall the chromosomes are normal, we don't know if there's a small amount of cells in that baby that may have another chromosomal issue that overall the baby is fine, but maybe what if in the liver that there's something like they have a few cells that have abnormal chromosomes to them. Does that make a difference to the baby? Probably overall not. But it would be really important to not be in like the eggs or the sperm of that baby. So I think, there is definitely literature and there are babies that are born from putting back abnormal embryos. But in my practice and at Yale, we never put back those embryos, which are called high mosaic embryos, because of the uncertainty of how those babies are going to turn out. But there are clinics, say in New York, under research sort of research consent that embryos are being transferred that have high mosaic embryos. So I don't think it's a standard of practice that people just put back the high mosaic embryos.
Yeah, absolutely. That's what I see in my work as well. So you've talked a bit about some of the interventions that can be
Sure.
used, right? Blood thinners, progesterone, things like that. Can you walk us through, as well as some of the diagnostics, but can you walk us through what a workup after 2 losses looks like and what people should know about that?
Sure. The standard workup that ASRM sort of tells all REIs, board certified REIs and practicing REIs is looking at the chromosomes of mom and dad. So that's a parental karyotype. To look at screening for the antiphospholipid antibodies. So that's anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein. And then looking at the thyroid hormone, TSH, looking at the hemoglobin A1C, which is to look for diabetes. I think one thing I hadn't mentioned before as a known cause is if there's something wrong with the uterus. I totally forgot to talk about that. So if a woman has a septum in their uterus, so there's like a kind of a wall in the middle of their uterus, that can lead to miscarriages. So we want to do an ultrasound on patients and then more specifically do something called a saline ultrasound to look at the cavity of the uterus to see, do you have a septum? Do you have fibroids that are pooching in? Do you have polyps? Because all those things inside the uterus could also lead to miscarriage. Sometimes I have patients who've had several miscarriages, and they've had, when I do the saline, they have scar tissue inside the uterus, and that can cause miscarriages as well. So that's another standard part of the workup. And so those are kind of the sort of evidence-based workup that everybody should be doing. And then the more experimental or things that didn't make it to the ASRM bulletin that I usually do for my patients. When I do the saline ultrasound, I take an endometrial biopsy to look for chronic endometritis as a routine. I also have the husband do a semen analysis to look at grossly the sperm, and I do recommend a sperm DNA fragmentation study. What I would say is that not all insurances will cover it, so I don't make that as a mandatory, you have to go and do that, and I leave it up to the couple. I say, hey, there's evidence that this is associated. This is something I can, have you get tested for, and we can, obviously we'll know if it's normal or abnormal, and then we can deal with that result. And then a lot of patients will come to me asking about reproductive and immunological testing. And so that's a very hot, controversial topic. But if my patient comes saying, hey, I've had everything tested and this is what I want, then I will send them for reproductive immunological testing, and I can interpret it in the with the sort of literature in mind of all the cutoffs, because the lab also has its own cutoffs. So what is abnormal, but there are definitely several studies that look at the cutoff for immunological testing as well.
Yeah, absolutely. And so it's my understanding that although I think, we can see from all of the contributing factors that there are immunologic issues that contribute to this, it doesn't seem as though the medicine at this point has a great solution to that. Would you agree with that?
Yeah, so I think that there is a lot of research into reproductive immunology in the animal literature, not as much in the human literature because it's very difficult to study. But there definitely is an immunological component to it, but I just don't think that we have a good test right now to say, yes, you have an immunological issue. The tests that we have available have shown that maybe there's something there. But I think also the treatment is we're not, when you're not quite sure what is the issue, it's immunological, but that's like a broad topic. Then if you use the treatments, it's like sometimes it works and sometimes it doesn't work. So I think it's just that we need more information about what the defect is. More recently, there's been some really interesting studies in England where they really heavily invest in research in miscarriages. And so there is studies that show that maybe there might be something with the lining of the uterus that is causing some women to have recurrent miscarriage. And they're actually looking at some interesting medications to maybe help with, that type of defect. And so I think we'll be, they're actually doing the clinical trials right now. So hopefully we will have some information about this newer medication that may be for a cohort, a subset of patients. So that's pretty exciting.
That is exciting. And we did have a question about if somebody has a donor egg and they're still having miscarriages, what could be the cause? So that would be one cause, that it could be a
yes.
uterine issue.
Right.
And then we have another question about just why wait for 2 losses? Why aren't some of these tests routine fertility workup?
So the reason being is that having one miscarriage is common among people. And to be honest, I think that if you wanted to find out and you have one miscarriage, you can have the chromosomes tested for baby, and that will probably give you the answer that there will be likely abnormal chromosomes. So that's why, so they used to wait until 3 miscarriages before doing testing, but now it's become 2 miscarriages because we know that couples who have 2 miscarriages are at the similar risk to having a subsequent miscarriage as 3 if you've had 3. So why wait until you've had 3 before you do the testing? So, but I think because 1 miscarriage is fairly common, hopefully most couples will not go on to have another. So that's why I think the cutoff is now at least 2 miscarriages.
And then this may be a harder question to answer without more background, but is there a number of miscarriages where you would recommend somebody move on to surrogacy? The question here, the questioner has had 4 losses at this point.
Yeah, so I have that question because I see a lot of recurrent pregnancy loss patients, and they're like, when should I think about other things? So what I would say is that it's a very difficult question, but we know that from literature following women who've had multiple losses, that even with someone who has 6 losses, and this is very dependent on age, obviously, that even women who have 6 losses will go on to have a live birth 50 to 60% of the time. So I always tell my patients, it's just how many losses can you go through to get to the baby? And it's really a personal decision because surrogacy is not an easy process, and expense-wise, it's definitely not an easy process. So it's really emotionally fit, the couple, can you go through another loss? If the answer is that I cannot go through another loss, then it doesn't matter if you had 3 losses. If you cannot, then you may want to consider a gestational carrier, but it really depends on the reason being why you're having the recurrent losses, because if it's an egg issue, then putting the embryo into a gestational carrier is not necessarily going to overcome that. So it really depends if it's a egg sperm issue versus if it's just a uterus and you issue. So that needs to be worked out before saying even, gestational carrier would be even an option.
Yeah, absolutely. So thank you. So for somebody who's having, a loss, even 1 or 2, is there a rule of thumb about what they need to do to recover from that loss before they start trying to conceive again?
Sure, that's a common question also. So really, the research hasn't shown that waiting for 3 months is going to make a difference. So it suggests that really, if you have 1 miscarriage, if you are ready to try again, then you are ready. But there's no you have to wait 3 months to get over your miscarriage before you can try again. So I tell my patients, if you have a miscarriage when your next period comes and you're ready to go, then go ahead. So it's really, again, how the couple feel about trying again, because some couples may feel they're not ready, they need time, but then some couples are like, nope, I want to get on and let's just forge ahead.
Absolutely. And then for those people that suspect that they're having losses, but they're very, very early and so they're not quite sure, and they're not in the category where they're going to necessarily be getting all of this testing done, do you recommend that they do regimental progesterone every cycle, or do you wait to test it or when they do become pregnant and then add progesterone?
So what I would say is that I include biochemical losses as losses, so the ASRM they recommend doing a workup after clinical losses, which means that you see a baby on the ultrasound or there is actual tissue. But in Europe, they actually count any pregnancy, basically early, like, oh, I missed a period and I have a positive pregnancy test, as a loss. And the reason I agree with them is that there has been research to show women who have recurrent biochemical losses, i.e., really, really early losses, are at risk of having more losses. So why should we wait until they actually have a clinical loss before investigating them? So in my practice, at least, I count early losses as a reason to start the workup.
Great. And then do you often prescribe progesterone just
Yes.
routinely after ovulation?
Yeah. So progesterone. So if I have someone, we've done all the testing, everything is negative. I routinely offer luteal phase progesterone. So 3 days after ovulation, I suggest they take progesterone and continue that through until they are pregnant and continue through the pregnancy up until 12 weeks. And so, yes, I do routinely offer that. And then for all my recurrent pregnancy loss patients, we do the tender loving care protocol where we see them every week until they get past the time they lost. Right, thankfully, most of my patients have gone on to do really well. So, small things. We don't have to be doing too many, throwing everything at patients. So I think sort of ruling out the things that we can rule out is the most important. Rarely do I have anybody that I've done every single test and there's nothing. I mean, and so those are very difficult. And those I, still give progesterone to, but it's kind of, there's, progesterone we know is safe because we use it in IVF. So the downside is minimal and the positive sides are potentially significant. So for those couples, I say, hey, we're going to give you progesterone. There's some studies that show maybe it'll be helpful, but I don't think there's a downside.
So we have talked about several different factors that can be involved, and then some clotting factors go in with that as well.
Right.
But why are some people put on blood thinners just without any diagnosis of anything, even low dose aspirin? Why are some people put on, Lovenox?
Yes, that's a loaded question. That may take a while to answer that, but so antiphospholipid syndrome, we know that baby aspirin and heparin is once pregnancy is once with a positive pregnancy test, that is when you're supposed to start that, and that has shown to make a difference. So if you don't have antiphospholipid, why are some women suggested baby aspirin? Why Lovenox? So for second trimester, so we're talking about losses above 12 weeks, then I think that some women will be tested for things like factor V Leiden, prothrombin gene mutation, and potentially those patients may have a mutation in those, and so they may be started on Lovenox because they have those genetic mutations for blood clotting disorders. So I think that is another reason. There was a study that was looking at just giving baby aspirin to all women, and to see if it would make a difference with just one miscarriage or multiple miscarriages. And that study really didn't pan out that it made a difference, either for one losses or two or more. So I think it's very difficult to not do anything for your patient. And I think the more I take care of recurrent pregnancy loss patients, I understand their need for doing something. And so many people may want to do something that's pretty inert, such as baby aspirin. as something to do. So I think that, weigh up the risks and benefits. And if your patient wants to do that, you're supportive. But definitely once you've conceived and you're pregnant, then definitely I see that people are doing combinations of Lovenox, baby aspirin, prednisolone, you name it, everything, and you just throw everything at the patient, even if testing is negative. And sometimes it works. And I've seen patients who did the whole, I had a patient who did everything. They did heparin, Lovenox, IVIG, and they still lost. But then they went back to the old-fashioned way of doing IVF and just genetically testing their embryo, and they had a live birth with nothing.
Right.
So,
Yeah,
so
I've seen the exact same thing where
yeah.
people, travel all over the world and do every kind of intervention imaginable, and then years later have a baby, naturally.
Yes, that too. I have patients who are like that, infertility patients who are like that as well. It's like, oh, you have diminished ovarian reserve, and there was hardly any chance. But hey, you can get pregnant on your own. That's amazing, which
Yes.
is great. So there are many things that we don't know about the human reproduction, that there's always a chance. Just as long as you have a uterus and ovaries and sperm, there will always be a chance. So I think I try to remain optimistic for my patients, that it will happen, and it's just that we don't have all the answers yet, and I wish we did. And so you just really have to be upfront with patients to say, I just don't have all the answers. I've ruled out everything I know, but we could try this, which has minimal, side effects, and let's hope for the best. And and usually, for whatever reason, it works out.
Yes, indeed. That is a perfect sentiment to close on. And I just want to thank you for your time and your insight and your wisdom and sharing it with us. This is, a complex topic, and I feel like we've had a rich conversation about it. So if people want to so thank you. And if people want to get in touch with you and work with you, is that possible? And how can they do that?
Sure. I'm at UT Health Austin, in Austin, and patients can just call and ask to come and be a patient of mine, and we can have a consult. Then UT Health Austin is where I'm at.
Wonderful. Thank you again, and we very much appreciate your work.
Thank you
Take
for inviting me.